Don't let my residents ever hear this.
It gets your mojo going.
It does. It's fun.
Probably be big rimping.
It's a safe place here. We're in the trust tree. I use inhaled sildenafil.
We're smoking like a round beer.
Yes, we are.
Dangerously drinkable.
Actually, lucitropy is a thing.
Hello, this is Echoholics Anonymous. My name is Jimmy Fair, and I am an echoholic.
My name is Brian Galovic, and I'm an echoholic.
I'm Josh Zimmerman, and I am an echoholic.
And my name is Mike Mallon, and I am an echoholic.
Welcome back, Echoholics. This is part 2 of our discussion about echo for cardiac arrest. I hope you enjoy. What is the role of echo, if we really break it down? What is the role of echo in cardiac arrest? And I think probably there's 3 main goals. One is rhythm analysis. So we know that the pulse check and rhythm analysis based on telemetry are very poor and error prone. And we can see whether there's VFib or VTAC or true cardiac standstill. So we can tell what the exact rhythm is. So rhythm analysis is one. The other is identifying reversible causes, like you mentioned, Josh. And certainly we can see evidence of whether there's been a pulmonary embolism or acute right heart failure, which would, in the right clinical scenario, presume to be due to that. We can see whether there's left heart failure. We can see whether there's pericardial tamponade or hypovolemia. So we can certainly handle a lot of the H's and T's as they're discussed fairly quickly with echo. And then the third and more controversial, I think, is just echo guiding compressions, which can be done with transthoracic, but also with transesophageal, probably much more easy.
No, I think one thing that we haven't really touched on too much is how terrible the pulse check is. Pulse check is a totally inadequate way to assess whether there's perfusion. We're very bad at performing it. And the studies that have been done on it, sensitivity ranges from 50 to 75%, depending on the patient population and who's performing the pulse check. So in a lot of ways, it kind of blows my mind that we're using the pulse check as our primary determiner as to whether somebody is dead or not. It makes a lot more sense to actually look at the organ that should be functioning in that case.
Most people forget when they're performing physical examination that you're asking a question. You're performing a diagnostic test that has certain test characteristics, right? It has a sensitivity and a specificity like any other aspect of what we do in a diagnostic pathway. And the pulse check, putting your finger on somebody's carotid to ascertain whether they actually have a viable pulse, has its failures, which appear to be pretty high.
So I think another interesting question that this kind of gets at is, if we are going to use echo in place of our pulse check, which I would personally recommend, do we halt compressions when we see that there is what appears to be a perfusing rhythm, but whoever's checking for the pulse doesn't feel the pulse? And so this image that's up right now, we're seeing some movement in the heart. Would you all stop or halt compressions based off of what you see in this image? There are no compressions here. This is a pulse check. Aortic valve's opening. Mitral valve is closing. But I would argue that this is not a perfusing rhythm.
So this is the difficult thing for me because I don't know what criteria we use for this.
We don't have any criteria. That's the whole thing about this, is that we don't know what a perfusing rhythm is. So here's the question. The question that Jimmy raised is an extremely pertinent question when it comes to echo during cardiac arrest. Just because you see function of the heart, does that mean it's time to stop compressions?
I would want to check out blood pressure here. What I can tell you is that there's severe mitral regurg and very poor cardiac output here, but this is a patient who they may need compressions to circulate the epi still.
That's the word. Epi. Epi is the word.
Compressions aren't all the same. You know, there's compressions to replace cardiac function and compressions to augment cardiac output. I can tell you guys, this happens to me all the time. I work with a very small group of providers in the cardiac OR, and I can tell those guys, Just give me a little bit. Just listen. Chest compressions aren't all 4.5 centimeters. I don't need to. I just need to get a little bit of epi through there because the truth is, you beat shit up, man. Like if you do chest compressions for 3 minutes, I can tell you, you create new problems. And if you need to, that's okay. But if you don't need to, you'll tear shit apart, man. You'll tear apart valves, you tear apart aortas, you create new problems all the time. So for this guy, I think let's just try half compressions for a minute with the giant bolus of epi to circulate the epi because something is contracting here.
So when I see this image, I think pressors. This patient is, they're not fast enough. If they're in the middle of a cardiac arrest, their heart should be moving faster. I would like to see more squeeze. This person needs some epi. Now, I don't know how much epi they need. That's definitely up for debate. Some people might hit them with another amp. That's what the AHA guidelines would say, right? If you don't feel a pulse in this patient, they would get another amp of epinephrine. I probably wouldn't give them that much, and I'm sure there's a lot of opinions here about how much this patient should get. But the bottom line is this patient needs epi.
This patient, I would maybe have somebody push on the chest just a little bit, but like Josh was saying,
it's massage. It's cardiac massage. We used to call it cardiac
closed
massage.
chest cardiac massage.
Sometimes a little massage can help, you know?
like most things, there isn't a black and white. Patient needs elephant-like compressions and patient doesn't need anything. There's a spectrum and there's some gray area in between where there's probably room for a more subtle management strategy.
So Brian mentioned a discussion with a resident earlier, and I hear this all the time. You know, we hear this, well, it must be easy for you guys. You work in an ivory tower. You've got minions. You've got a bunch of people doing your stuff. I'm a lone doc working in a private practice hospital. You know, when there's an arrest like this, it's just me and my nurse. And I don't have time to look. I don't have time to be fooling around with this echo because I have to be managing inotropes and compressions and directing the arrest.
If you did have a TEE, even in a community setting, you place that TEE in a mid-esophageal 4-chamber view, right? Or a long axis if you like, whatever you want to do, and you leave it there and you walk away and it stays there and you run the code with constant visualization of the heart.
This image here, to me, is totally different than the first one you showed us. And my response to those providers is, you're doing all of this for what? Because you don't know what's going on. You're managing all of this arrest in a situation where if you're not looking, you have no idea what's actually going on. And managing this patient, like the first patient that is in cardiac standstill, is totally ridiculous. You know, it takes you less time to place the probe than it does for the machine to boot up. You know, if you don't look, you don't know. You just don't know.
So this image, I think, shows a little bit of valve motion in that tricuspid valve, which we're seeing right over here. This is cardiac standstill, but at the same time, there can be some valve motion. And most of the time, that's related to somebody providing some positive pressure ventilations. And so it's pretty normal to see some positive pressure ventilations causing some valve motion. And that's not a reason to stop compression.
Yeah, I've seen this quite a few times, and I think that a nice caveat is that if you're considering stopping compressions and you're really trying to assess whether there's cardiac standstill or not, actually hold ventilations too. In that case, it makes it super easy to say, yes, there's truly cardiac standstill, because I've seen cases where a ventilation can cause more cardiac function than even what we're seeing here, where it actually looks like the heart is almost squeezing. I mean, it really looks like, you know, organized cardiac function where you see movement of the tricuspid, the mitral, the whole heart moves and the whole heart appears to almost squeeze, and that's from the increased thoracic pressure secondary to the ventilation. And I think it's important that if you're going to call the code, just go ahead and hold ventilations while you're at it and make sure that there's no cardiac function.
So Mike, do you think you've seen VFib that created less motion than that?
I have seen VFib that does not create valvular motion like that. Yeah, absolutely. In fact, most of the cases of VFib that I see, there's no valvular motion. All you're seeing is that bag of worms appearance of the ventricles. And, the thing that I often also see in VFib is this sort of like swirling of the blood. That's been helpful for me too, especially in the atria. Like right when you finish compressions, you see the swirling of the blood in the atrium. That I'm not sure why I particularly see it, but that seems to be fairly consistent in the TE images of VFib that I've seen.
Speaking of which, great segue. So this is Jimmy's bag of worms, and that's what VFib looks like. So here at the very end of the clip, you see it get shocked, and then we're kind of left wondering what's going to happen after the shock.
What's going to happen, Jimmy?
Well, it took a few shocks. We shocked several times, but here's maybe the coolest image I've captured, which is a shock happening right here, and then restoration of sinus rhythm there.
You know what's interesting about VFib to me is that we all talk about how it's a diagnosis you should make on the rhythm strip and not on echo. Yet, in the 3 cases of VFib that I've seen intra-arrest, after the patient's been, coded for a while, for whatever reason, they go into VFib, totally unexpected VFib. All 3 of those cases, we diagnosed it with echo, and then we confirmed it with the rhythm strip. There was somebody looking at the echo. No one was looking at the freaking rhythm strip. And then all of a sudden, the person looking at the echo was like, hey, I think that's VFib. And then everyone looks up at the rhythm strip, and they're like, oh, yeah, maybe we should shock them.
Yeah, which is what happened in this case. Yeah, which, honestly, at this point, you see that turbulence in the right ventricle, and that's because this patient just got placed on pump. And so there's perfusion going on despite this patient being in VFib that's causing no cardiac contractility. But at the same time, even if you're on pump, if you have true cardiac standstill, that's not necessarily a good thing, because you just have a ventricle that's filling with clotted blood potentially. So it's certainly good to get this patient back in sinus rhythm, and we were able to identify that much earlier based on having a transesophageal echo, that giving us real-time feedback and able to say, yeah, we need to shock this patient. Yeah, we need to shock him again. Yeah, we need to shock him again. And then eventually they stayed in a perfusing rhythm there.
Yeah, what's interesting about this patient to me was that they stayed in cardiac standstill for probably half an hour or so, and then within about 60 seconds of being placed on pump, they went into VFib. I mean, it was so immediate.
Yeah, and that's kind of a phenomenon we've been seeing with this new project is once we get the patients on pump, what has been asystole and true cardiac standstill turns into a pretty brisk rhythm. And
so this person, I think, got like 5 shocks, cardiac standstill for half an hour to VFib and then ROSC within 2 minutes of being placed on pump. That is impressive.
Right now, some of you may be thinking, transesophageal sounds nice, but the reality is I don't have it in my current practice environment. And I try to use transthoracic, but find the images difficult to obtain in the limited time frame that I have. And I get gel all over the chest, which makes it difficult for people doing compressions to do effective compressions. So what are some tips to help those of us using transthoracic? We try to address those concerns.
the reality is most people don't have a transesophageal echo, which all of us would agree, I think, is ideal for cardiac arrest resuscitation. But the idea is you want to limit the time that you're spending away from chest compressions. And so I think we should just touch on a little bit how practically to use transthoracic echo in cardiac arrest scenarios.
I think so. In my utilization of transthoracic echo, I like to be ready to go. So while compressions are ongoing, I try to take a look at a subcostal window to see whether I'm getting in the ballpark of something useful.
It's interesting. I've seen the subcostal for me has been challenging. I think mostly because these patients get a lot of ventilations and tend to have pretty big stomachs. So I've had a lot of trouble with these subcostal windows in these patients. So for that reason, I tend to try for the apical windows a little bit more, because you can also get those during compressions to some degree with varying success. It can at least get you in the right ballpark, right? Kind of like you were saying, Brian, like while they're getting compressions, you see a little something going on, indicating that you might be able to get a good window once you hold compressions. And then just like you, I sort of hold back from my peristernal long axis as my backup if I can't see anything apically or subcostally, holding the towel in my hand, ready to sort of, gel already on probe, ready to put the probe on the chest immediately after compressions are held and wipe off the gel so that the CPR provider doesn't have to deal with the gel when they restart compressions. Yeah, and I think a good principle to remember here is that the echo is not saving this patient's life. What's saving this patient's life, if anything, is the CPR that's being provided. So what you're doing is secondary to doing the compressions. Now, granted, there could be something very important on that echo that you need to diagnose, but bottom line, what needs to happen is this person needs to get compressions. So if you can't get an image and it's been long enough, stop, restart CPR, try again later, do something different. Don't continue holding CPR to try to get a good image.
So let's wrap this up. I think some things we can take away are that echo is important in cardiac arrest. Cardiac arrest is not one entity with one etiology. It's many entities with many etiologies. And echo can give us a few different very helpful guides. One is rhythm identification. 2, we can identify reversible causes of arrest in order to guide interventions. And then 3, and a bit more controversial, we can actually guide compressions and compression quality. Certainly echo use in halting compressions is another controversial area and requires a bit of experience in order to say, yeah, you think this is a perfusing rhythm, let's stop and take a blood pressure, or no, we don't think this is a perfusing rhythm, get back on the chest and do some more compressions. And then if you are using transthoracic, the big point is to limit the amount of time that you're imaging and taking up that prime real estate of the chest in order to facilitate resumption of chest compressions in order to continue perfusing as much blood as possible.
So the deal is, like, we can debate the value of TE versus transthoracic, but at the end of the day, the best image is the image you have. And if you don't look, you don't know. You really don't.
I don't really think I have anything to add. I think that, whether you've got TEE or transthoracic echo, the important thing is that you recognize the limitations of the current guidelines for cardiac arrest, and you recognize how much echo can improve the care of our patients and your ability to prognosticate and diagnose and treat these patients in front of us.
And that's it for this episode of Echoholics Anonymous. Please leave us your comments at www.echoholicsanonymous.com. Music by Big M and the Little Organs. We'll see you next time.